So now we're going to turn to our first panel, and we're going to dive deeper into the impact of the epidemic on care of those with serious illness, both the impact of the epidemic itself and the reactions to it, and understanding how it's affected patients and the clinicians caring for them. To guide us through this session, we're lucky to have Sean Morrison, another of our hard-working double-duty planning committee members who also is going to participate today. Sean is the Ellen and Howard C. Katz Professor and Chair of the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai, and Sean will introduce the other panelists and speakers.
Thanks, Andrew. So good morning, everybody. We've got a really interesting session this morning, and let me just start with a couple of introductory remarks about what we're going to do over the next hour and 40 minutes, if I get the timing right. As many of you have heard this morning, and indeed why this workshop exists, is that we are faced as a nation and indeed internationally about how do we balance the needs of the seriously ill with the unintended consequences of opioid use. And for many of us who are living in this world, when the regulations and the discussions around opioid use come about, there is always this clause that says, well, of course we don't want to limit use for people who need them. And then that goes a little further, and of course we don't want to limit use for people who are dying or have cancer. And unfortunately, there are millions of Americans who are living with serious illness, who are living with pain, who truly do benefit from the analgesic effects of opioids. And the lack of access and the lack of ability to obtain these medications can have real consequences. Joan, that was a brilliant talk. However, I'm going to take issue with 2 points that you made, and only because you talked about language. The first was your comment that there's a suggestion that pain is undertreated in this country. There is no suggestion. The science on the treatment of pain is absolutely clear. Pain is undertreated. Now, whether or not opioids are the direct response to that or not, that's the question, but pain truly is undertreated. The second is to dispel the myth that untreated pain doesn't have consequences. It has real consequences, and the science behind this is also crystal clear, that undertreatment and non-treatment of acute pain results in chronic pain syndromes and disability, and I've done the research to do it. I saw the shaking of the heads. We can have that discussion. Okay. But clearly that untreated pain has consequences, and it has consequences for people with quality of life. Over a decade ago, my dear friend and colleague, Rosanne Leipzig, who I have worked with for almost 20 years now, came to me and asked me if I could be the palliative care physician for her wife, Aura Chaikin. There is no greater both honor and, quite honestly, terrifying experience as having a colleague ask you to take care of their loved one. And what we're going to do this morning is, and I'm going to ask Aura and Rosanne to talk a little bit about why Aura came to see me as a palliative care physician, be a little bit about the disease that she's been living with for over 2 decades, and the symptoms that she's been having to manage. We're going to talk a little bit about how opioids truly have been life-saving for, again, many more years longer than is typically recommended, and at doses which are higher than what the regulations suggest. And finally, we're going to talk a little bit about how difficult it has been and the stigma associated with that, or attempting to get medications that have been truly life-saving. I'm going to ask them to talk for about 10 minutes or so. We'll open up. I'll have some questions for them, and then we will turn to our expert panel and their presentations, followed by questions and answers at the end. Does that work for people? If it doesn't, we all three have pretty big egos, so if you want to walk out and get coffee, we're okay with that too. It's not going to upset us terribly. So let me turn it over to Aura and Rosanne.
I'm starting. Aura's illness started at least 25 years ago. She will tell you about what was going on, but we were going from doctor to doctor to doctor, essentially with no diagnosis, or with diagnoses that partially accounted for her symptoms, but things kept going. So she received a diagnosis of Behçet's, she received a diagnosis of Sjogren's, and she was having erosive arthropathy with tendon and ligament failure, destruction, actually. And she was in a lot of pain. And everybody wanted a diagnosis to explain this. And there was none when you did the conventional studies. And at that time, she didn't look as if she had any of the classical autoinflammatory diseases. So I asked Sean, because I felt that she needed pain relief. And just one piece back on that. So in my training, I'm a geriatrician and palliative care doctor, but I did my fellowship in clinical pharmacology in what was called a supportive care unit at Cornell, which I think was the precursor of palliative care, okay? And what I did was to try and understand why people need different doses of opioid medications, and we did HPLC, which is 100 years ago. But it was very clear that people metabolized it differently, and some people needed huge doses, and some people didn't to get the same blood levels. So I was pretty comfortable with the idea of using as much as you need to get functional relief, because this was really affecting her function. She was stopped working in '92 because of all of this. And so I've been on the journey with her since 2000 to understand how much she needs and how to get it in a way that doesn't cause as much problem as the disease itself.
Okay, I've had a chronic disease for 25 years that destroys my tendons and joints. For the first 7 years or so, my diagnosis was unclear, and it's still unclear. Rosanne said I quit work. I quit work because at that time I had an infectious disease. They had low T cells, and they said you shouldn't be working in a hospital environment. So that's what happened there. Not because of the disease I have now. Be clear. Okay. In the late 90s, I was diagnosed with Behçet's and Sjogren's and treated with nonsteroidals, Plaquenil, and methotrexate. The pain in my hands and feet were getting worse, and I was developing neuropathy in my feet. In 2000, when I saw Sean, the pain in my feet and hands made it difficult to walk, to perform activities of daily living, and I really was at my wit's end. I consulted a new rheumatologist and internist. Your name, you're outed now. After evaluation, the rheumatologist diagnosed me with RA, even though I didn't have the RA factor, and started me on steroids, increased the methotrexate dose, and I started Emerald injections. That was the beginning of the biologicals. Fortunately, the internist I saw was also specialized in pain management, and I was started on opiates. In addition to opiate treatment for pain, I have also done I meditate daily and do visualization techniques, which I think helps too. So over the next few years, the pain started to really increase and develop in other joints, my shoulders, back, hands and feet, and my hands and feet started to become very deformed because the tendons were breaking. I was having difficulty walking also because of back pain. So in 2004, I need something to drink. In 2004, Sjogren's gives you dry mouth. In 2004, I had a back fusion with a graft, and complications from that back surgery included a fracture of the pelvic ring. It was undiagnosed for 6 months. I still have a fracture in the pubic ramus area, which is not fun. From 2004 to 2015, I had multiple surgeries, including bilateral reverse shoulder replacements, bilateral foot reconstructions, and I also had a placement of an intrathecal pump, which had to be removed because I developed myelitis. My RA has been treated with all the new biologicals, and none of them have worked. I'm on a new one now, and I'm cautiously optimistic that it may help. My rheumatologist often refers to my disease as the Chaikin disease. My relationship with opiates has been quite difficult. When I initially started the opioids, I would periodically flush them down the toilet or throw them in the trash because I didn't want to be taking them, and I didn't want to be labeled an addict or become dependent, actually. I just felt I could beat this some other way. But I eventually accepted it because I wasn't able to function on a high level. And I realized I needed to be treated, and treated adequately. Early in my opioid treatment, I received a letter from my pharmacy benefit company telling me they were cutting my medication in half. They said my dose exceeded the amount, exceeded the maximum dose, I guess. My internist and Rosanne called the insurance company like so many times with no results. And finally, fortunately, Rosanne happened to know the chief medical officer at the insurance company. And over many weeks, it took many weeks for this to get straightened out. And of course, during that time being resolved, I went into withdrawal, which isn't fun because I had no medication. However, the problems continued once this was resolved. Included things like and Dr. Morrison can tell you about this. If he doesn't dot an I, they reject it. I mean, every time it seems there's a problem, and they just they don't want to fill it. I mean, the bottom line. And every month I worry about being able to get them. Then I feel like I'm an addict. Then I feel like, there's something wrong with me, and people are still judgmental. The reps that I deal with are, often tell me, we got to get off this medication, it's no good for you, So it's, I'm made to feel really like an addict. So I had used, I think the worst experience for me was at a local pharmacy that I'd used for around 30 years. And the pharmacy was sold, and there was a new owner, and I went in for my usual script, and I was told that he didn't want people like me in his store, and that if he filled my script, he would lose his license. This is after 30 years, and the previous owners were still working there, but they could do nothing about it. So, and he screamed. I mean, he screamed in a store filled with people, that I was, an addict, and he didn't want to deal with me. And I have to say, that's probably the worst problem for me, taking opioids, because of the judgment that I get. I don't tell my friends. I don't tell people. I'm very cautious about who I tell, because despite the fact that people say they're not judgmental, they are judgmental. So, and then I recounted, I recounted recurrent, recurrent problems with the mail order pharmacy. When the scripts are eventually filled, of course, it's always late, and I have started to play game. I start to taper myself so I don't run out, but then I get increased pain. And they won't even expedite it. Even if I pay for it, they will not expedite the drugs to me. For what reason, I don't know, because I pay for it. In addition to increased pain that I, excuse me, in addition to the increased pain I encounter with difficulties getting the opiates, I'm made to feel like I feel like a criminal. I feel like a criminal, basically, and it doesn't feel good. Being treated with opiates allows me to have a relatively normal life.
I just want to add one thing to that. Aura has, in addition to all of that, severe spinal stenosis. You can see her hands. We just came back from an extraordinary 3-week trip to the Middle East and Eastern Europe. And if she had not had these medications, it would never have happened, okay? And I mean, she has all sorts of things she does to get her through. It's not just the medications. We'll be walking and suddenly you'll see her squatting and bent over to try and open up the spinal stenosis. When the guide is going on for a few extra minutes, she takes that time to do that. In terms of function and having a real life, these medications have made all the difference in the world, plus her incredible attitude toward getting through this.
And just before I ask you guys a couple questions, just a couple things that Aura and Rosanne didn't mention. She has gone through multiple non-opioid therapies, including, as she said, an intrathecal pump, which had to get pulled out in an attempt to reduce her opioid requirement. Her dosage has stayed exactly the same, except for acute exacerbations throughout this period, and it has allowed her to function. We have done multiple opioid rotations because of various side effects. We thought we had finally gotten it when extended release hydromorphone was on the market. It was the one opioid that had fewer side effects for her, allowed her to get through the day, and then it was taken off the market. And let's face it, folks, taking hydromorphone every 3 hours around the clock is not compatible with a normal life existence, particularly when you have to get up in the middle of the night. So we are back to an extended release opioid, which gets her through the day, I would say. I mean, both of them talk about, how well she's doing. The reality, I would say, Aura gets through the day, and that's where we are. One of the things that you mentioned, but I did want to highlight a little bit, is, Rosanne, you went through this with me. Can you talk a little bit about what happened when, I won't mention the very large insurance company that also has a drug plan, essentially without warning, without notification, just stopped filling a prescription that we had been
Holding on to things is a problem.
sending for, I guess, 5 years.
Yeah. So suddenly, over the course of a couple of days, we got a few letters in the mail. And the letters included one that said, we're cutting your opioid dose. The second that said, we're cutting your diamphetamine or methylphenidate or whatever she was on for fatigue dose. Same time, okay? And I'm not sure if we got something saying they were cutting your steroid dose or not. Yeah, they did, yeah.
And I did not get any of this, by the way,
Okay.
as her treating physician, did not get any of these notifications.
So, we called the pharmacy and we got pharmacists who basically read from their script telling us why. And I tried to bring up issues like withdrawal, like the fact that this was working, like the fact that this has been for 5 years that we've been doing this. And we kept getting bumped to other pharmacists, but we weren't getting anywhere. And I remember one day you and I sat in your office and talked to this guy who I actually ended up feeling badly for because he's a pharmacist. He knows that he shouldn't be doing this. And he said that, but he said, there's nothing I can do. And that was the point where I went and I looked to see who was running the company. And I had happened to be on panels with the CMO. And I wrote him a letter. And it still, as Ora said, took 6 weeks until it was straightened out again.
And as Lori's looking at me, in the 18 seconds that we have left together, I would also, just add to that, Ora's not an exception. Hear a story like Ora's and you say, oh, this is unusual. I have an entire patient panel of people like Ora. They are quiet. They feel that this is only them, that they feel that they're not empowered, and they feel pretty powerless and helpless. And these are the folks that are not making the New York Times. They're not having books written about them. And yet these folks are suffering, I would say, tremendously. I will not tell you how many hours of my time was spent writing letters, talking to pharmacists, talking to the CMO for, my patient. It's an NIH grant I didn't get done.
Can I add one thing?
You may have one thing, and then we're going to move to the panel.
Okay. The one thing that gets me the most is seeing over and over again that there is no evidence that opioids work for chronic pain. And lack of evidence is not evidence of no effect. And I don't know how we get people to recognize this, but there's an N of 1 right here, and I'm sure there are plenty of them that you've taken care of. And somehow we need to get that message out.
Amen.